Welcome, everybody. Let's go ahead and get started. This is the Department of Internal Medicine Grand Rounds. Today's session is sponsored by the Division of Pulmonary and Critical Care Medicine. We'll be talking about asthma. Our two speakers today are Dr. Farrukh Abbas and Stephanie Bork. So let me introduce them and then we'll go ahead and get started. So Dr. Abbas completed his medical residency in Rochester General Hospital in New York and worked as a chief resident before pursuing his fellowship in pulmonary disease and critical care medicine at the University of Rochester. His research and clinical interests include severe asthma. During fellowship at the University of Rochester, he was awarded a prestigious Bordley Award for fellowship teaching for his excellence in educating the internal medicine residents. He's currently serving as a panelist on the CHEST ACCP Committee for Severe Asthma and Asthma COP Overlap Guidelines. He's also a member of the CHEST Airways Network. Stephanie Bork is a family nurse practitioner and faculty practice member with appointments in the VCU School of Nursing, as well as the Department of Medicine, Pulmonary and Critical Care here at MCVP. She trained at the University of Pittsburgh and the University of Pennsylvania. Her clinical focus is in allergy and asthma in both pediatric and adult patients. She recently relocated from Philadelphia, where she managed pulmonary patients at the Corman Lung Center at Jefferson. Her research interests include professional practice of advanced practice providers, severe asthma comorbidities, and biological therapies and health literacy in asthma. We'll start with Dr. Abbas here, and then Dr. Bork will come up. Please join me in welcoming Dr. Abbas to our session.
Thank you so much for the introduction, and thank you everyone for joining. That's me, that's Stephanie. Today our objectives are to discuss different asthma phenotypes, to discuss how to assess uncontrolled asthma, how to assess risk factor for asthma exacerbations, and to review the impact of comorbidities on asthma. We'll do all this while discussing a case, so we'll highlight important aspects of this case, and then we'll try to achieve our learning objectives through the case. Before I discuss a case, this is a little bit older slide from 2006. This shows rising asthma incidence. We know about 262 million people in the world have asthma, and 1 out of 12 people in US, that is about 27 million people in the United States, they have asthma. And we have seen rapid rise over 40 years in asthma incidence and prevalence that cannot be explained by genetic factors alone. So we're thinking probably environmental factors are playing a big role in rising asthma incidence. In Richmond, from 2020 to 2020, we have seen that within Richmond City, the asthma-related hospitalizations are at least twice compared to the rest of the Virginia. I'm sure there's a lot of healthcare disparities that are playing role due to socioeconomic factors here, but we see a lot of asthma patients, a lot of uncontrolled and severe asthmatics in Richmond City. And this is from Asthma and Allergy Foundation of America. They publish every year asthma capitals of the United States. And pretty much every year, Richmond is within first 20 cities. This is based on asthma prevalence, ED visits, and asthma-related deaths. And this year, Richmond was rated as number 7 city as the worst city for asthmatics. And it was rated second worst in 2015. So with that background, I'll start with this case that I saw in my clinic. So 38-year-old woman who was non-smoker with no significant past medical history. She had COVID in 2021. And then a few months after COVID, this COVID was mild, managed at home. A few months after that, she started having dry cough, shortness of breath, wheezing, and chest tightness. Symptoms were worse at night, which is typical for asthmatics, and with seasonal change. Her triggers included exercise, viral infections, dust, and bleach. There was no evidence of mold. She was living in a new house, and there was no indoor pets. So before the patient saw me, this patient required prednisone burst about 7 times in the last 12 months, including 3 ED visits and 1 admission to the medicine floor. So despite ED visits and hospital admission, this patient was continued on albuterol only, which is short-acting beta agonist. While the patient was having daily symptoms. So I wanted to point here the importance of inhaled corticosteroids in asthma patients. So we have seen a big shift in 2019 from Global Initiative of Asthma Guidelines. So over last 3 decades, short-acting beta agonist was recommended as a step 1 for asthmatics, which is no longer recommended, even if they have a good asthma control. So if patient has asthma or suspected asthma, it will be a disservice for that patient if the patient stays only on short-acting beta agonist, because we know that albuterol-only therapy is associated with increased risk of asthma-related deaths and increased risk of healthcare utilization due to asthma. This one study showed that they looked at patients, about 30,000 patients, and looked at patients who died due to asthma. And they saw that each additional canister of ICS used in the previous year decreased the asthma-related death by 21%. So that shows the significance of why the patient with asthma need to be on an ICS-based inhaler. And this other study showed that about 23% of the patients who were only on reliever therapy, that was short-acting beta agonist, had needed urgent healthcare need in the previous year. And these were the patients who were not happy with their asthma control or asthma management. This is a slide from GINA 2023. We know that there are 2 tracks for management of asthma that's recommended from GINA. In the preferred track, it is the low dose ICS formoterol recommended as step 1 as only as needed therapy. And other track is those patients who cannot afford or cannot take ICS formoterol as step 1 therapy, because we know ICS formoterol is recommended but not approved to be used as needed therapy by FDA. So the other track is that whenever a patient takes short-acting beta agonist, it is recommended the patient takes ICS. So these for the track 2, these patients usually need 2 different inhalers as step 1. So back to our case, this patient who had chronic daily symptoms saw me in clinic. We started patient on budesonide formoterol inhaler and to be used on a scheduled basis. And the reason that I chose it on a scheduled basis is because many of these patients, when I start them on maintenance reliever therapy for ICS formoterol, it is not covered by their insurance because they finish their canister before the month ends and they have to wait for 30 days. To get a refill. And my understanding was this patient will need at least 2 puffs twice daily. So we'll finish the inhaler before the month end. So that's why I started this patient on short-acting beta agonists as a reliever therapy instead of ICS formoterol as a reliever therapy. Patient was hemodynamically stable. Patient was noted to have bilateral expiratory wheezes on auscultation. And these were the lung function testing of this patient, which I was pretty much surprised to see. You can see this patient has a FEV1 FVC ratio of 49, which is pre-bronchodilator, and FEV1 was 51% of predicted, which is pretty close to being severe. So it was moderately severe obstructive lung disease and has significant close to 50% bronchodilator response. But still, this patient had post-bronchodilator FEV1 FVC ratio less than 70. So patient had some, partially reversible obstruction. And this patient had evidence of air trapping, severe air trapping with this residual volume, which was 4 and 48% predicted, and evidence of hyperinflation and normal TLC, normal diffusing capacity, which is pretty typical for asthmatic. We see that patients with COPD have more fixed obstruction, but sometimes we see in asthmatics patient as well. It was pretty impressive in this patient who had asthma for only 2 years to have this severe obstruction. So in this patient, GINA recommends different steps for asthma assessment. There are 3 different components. One is asthma control. Second is treatment issues, and third one is to address comorbidities. In asthma control, there are two components that come in asthma control. One is control of the symptoms, and second is to assess and reduce the risk of exacerbation. So we'll talk about that, how do we control, how do we assess asthma control, how do we assess risk of exacerbations in our clinic. There are different ways we can assess asthma control. One of the most common questionnaire that we use is called Asthma Control Test, or ACT. It's a pretty simple 5 questionnaire. Each questionnaire has 5 items and asking about patient symptom in previous 4 weeks, rating from 1 to 5. And a patient who has score of 20-25 is rated as well-controlled asthma, 16 to 19, not well-controlled, 5 to 15, very poorly controlled asthma. And the difference is minimal clinically important difference is 3 between different times or different patients. So there's a significant difference. Our patient ACT was 12, which is consistent with very poorly controlled asthma. How do we assess risk of exacerbation? So just a mind game. It's a quick question. You can think in your mind. What will you choose? Which of the following factors places a patient with asthma at much increased risk of acute asthma exacerbation? A FeNO of 15 parts per billion, ED visit 3 years ago for asthma exacerbation, but never intubated, albuterol use for wheezing once a day, FEV1 69% predicted with 4% improvement post-bronchodilator. So the correct answer here is albuterol use for wheezing once a day. And we'll talk a little bit more about it. FeNO of 15 parts per billion is within normal range, so that is suppressed. And we know a higher FeNO, and we'll talk about that, does increase risk of asthma exacerbation. ED visit, when it comes to ED visit, it usually within previous 12 months increase the risk of exacerbation. But if the patient ever intubated, that increase the risk of future exacerbation. Daily albuterol use and abnormal lung function. If this patient has improvement of lung function, which is pretty significant, so that would not qualify. So these are the common risk factors for exacerbation, include uncontrolled symptoms, high SABA use, more than 2 canisters per year. So many times I see patients in clinic who are using 1 canister a month or 1 albuterol puff a month as rescue, and patient have no clue that that does increase risk of exacerbation. If the patient is only on albuterol without ICS, that also is a risk factor for exacerbation. If the patient is using 1 or more canister per month, that also associated with increased mortality. Type 2 inflammatory markers, if they're high eosinophils, elevated FeNO, especially in patients who are taking ICS, increase the risk of exacerbation. The patient ever intubated or been in ICU for asthma-related exacerbation. Other risk factors include 1 or more severe exacerbation that require hospital admission, or multiple mild to moderate exacerbation that are usually managed on outpatient basis in the last 12 months. So out of all these risk factors, our patient had multiple risk factors. So our patient is really very high risk for future exacerbation. So when I saw this patient in clinic, so certain things that we do, we check different biomarkers to assess asthma phenotype, and we'll talk more about why phenotype is important. When I first saw the patient in November 2022, EUs were 100, IgE was 50. So the normal range of IgE is like less than 30 is normal, but 30 to 700 is the cutoff for using omalizumab. So this was like just a little bit higher than the lowest range, and FeNO was 23, which is not high. So I saw the patient again in February after starting this patient on ICS formoterol. This time, again, EUs were suppressed. Patient still was uncontrolled, was having a little bit less exacerbation, but still had 1 more exacerbation. So I added a LAMA on this patient and saw the patient again in August. Patient was still uncontrolled. This time when we repeated eosinophils, they were 1,000 and FeNO was 55. So The reason for this timeline slide is the importance to highlight here that we have to check these biomarkers multiple times, sometime to better identify the phenotype of this patient. Because when I saw this patient in August, now I was thinking about step 4, step 5, which is adding biologic in this patient. But these biomarkers help us to use what type of biologic, to choose what type of biologic we're going to use on this patient. So I was initially thinking a different biologic, but when I saw this eosinophils, then I was thinking about a different biologic in this patient. So Gina recommends that we check blood eosinophils and pheno up to 3 times in different times of the year, in order, at least 3 times, in order to better phenotype these patients. And usually these patients, if they have taken oral corticosteroid, that would suppress their eosinophils, that would suppress their exhaled nitric oxide, and they recommend at least waiting for 1 to 2 weeks after oral corticosteroid. Those are on the lowest possible OCS dose. If my patients can come off OCS, you usually give them at least 10 days break before I recheck CBC with differential. So our patient who's 38-year-old, new diagnosis of asthma, which is poorly controlled. We discussed multiple factors which puts this patient at high risk of future exacerbation. We saw this patient has positive bronchodilatory response, but partially reversible airway obstruction. Patient has high eosinophils, high phenome, and low IgE. I wrote low because it was just not too impressive. So what do we think is the phenotype of this patient? So I think before we talk about what phenotype this patient has, can talk about what does phenotype mean and what does endotype mean. Phenotype is usually an observable characteristic of a disease based on morphology, development, or common biochemical pathway or physiological properties. While endotype is a subtype of disease that is defined by a distinct molecular mechanism or a treatment response. For example, if a patient has emphysema due to alpha-1 antitrypsin deficiency, there would be endotype of emphysema. Now we'll talk about different endotypes and phenotypes of asthma. One common phenotype, which is eosinophilic asthma, as we call it type 2 high asthma, or sometimes we call it type 2 immune asthma. I'll talk about the difference between type 2 high and immune. It's just the terminology. And that's represented in this slide. It can be both allergic eosinophilic asthma, it can be non-allergic eosinophilic asthma. So in an allergic, there'll be an allergen at the airway epithelium. So that allergen will be taken by dendritic cells, and they will take the allergen to a naive T cell. In the lymph node, that naive T cell will be converted into Th2 high, T helper 2 cell. And there's also sometimes these, what we call epithelial alarmins, IL-33, 25, and TSLP, that are released directly by epithelial cells, and they can trigger this conversion of naive T cell to Th2 cell. And this Th2 cell then produces different cytokines and interleukins. Common interleukins produced are IL-5, IL-4, and 13. So IL-5 is involved in eosinophil maturation and migration towards the airway epithelium, and there they will cause inflammation. IL-4 and 13 have their own role. So IL-4 and 13 not only induces goblet cell hyperplasia here, and IL-13 also involved in phenoproduction, while IL-4 and 13 also involved in IgE class switching. So they work on the B cells and involved in IgE production. So that's how they're involved in allergic eosinophilic asthma. Eosinophilic asthma can also be non-allergic, and non-allergic pathways would be basically viruses, other microbes, irritants, pollutants, smoke, affecting on airways. The airways would produce these epithelial alarmins, or would directly be the natural killer cell will be taken by macrophages and natural killer cells, and they'll produce IL-33. And these epithelial alarmins work on a cell called innate lymphoid cell, or ILC2. And this innate lymphoid cell can in turn produce the cytokine that are produced by Th2 cells, especially IL-5 and 13, and they'll induce eosinophilic inflammation. So before this ILC2 cell was recognized, we used to call it Th2 high asthma or type 2 high asthma, or sometimes people used to call it type 2 asthma. When this was identified, then we knew that eosinophilic inflammation can also be without Th2 cells. So that's why now people use the term of type 2 immune asthma instead of type 2 high asthma. But pretty much means eosinophilic inflammation through a pathway mediated by ILC2 cell. This another slide. I'll talk about type 2 low asthma here, but before that, the criteria to define type 2 high or type 2 immune asthma is eosinophils, peripheral eosinophils more than 150. Usually for treatment response, we use it 300, but for definition, it's 150. Pheno above 25. If we're able to check sputum eosinophils more than 2%. So in this slide on this left side, you see this allergic asthma and non-allergic eosinophilic asthma. It pretty much shows the same pathway that we discussed, type 2 high and ILC. On the right side, you see this type 2 low asthma, and it's just that we don't know much about type 2 low asthma. So it's pretty much dissatisfying definition because we don't know what type of asthma it is. So that's we just call it type 2 low or non-type 2 asthma. But the cells that so far identified are Th1 cells and Th17 cells. Through neutrophil and macrophages, they induce either airway inflammation or plus smooth muscle cell hypertrophy. And that can cause airway hyperresponsiveness in these patients. And here are different biologics and their targets. So these biologics started, the first biologic that was identified as omalizumab in early 2000. And for many years, this was the only biologic that was used. And this was basically anti-IgE. And omalizumab binds to IgE. And so this was the biologic that was available for many years, but this could only target allergic type of eosinophilic asthma. Then since 2013, we have more biologics, especially IL-5. And so this mepolizumab and reslizumab. So reslizumab is only IV infusion-based therapy, and mepolizumab is home injection. They bind to IL-5, and by binding to IL-5, they reduce eosinophilic inflammation. Dupilumab, which is a blocker of anti-IL-4R receptor, which is a common receptor that's shared by IL-4 and 13. That also not only works by reducing eosinophil, but also works by working on IgE. And then benralizumab is a IL-5 receptor blocker. Then tezepelumab is the most recently approved biologic for asthma, which binds to TSLP, the epithelial alarmin. So tezepelumab can work not only for eosinophilic asthma, can also work for non-eosinophilic asthma, as you see. And that's the only biologic that can be used for non-eosinophilic asthma. Although sometimes we use dupilumab as well if the patient is dependent on oral corticosteroid and still has no evidence of eosinophilic inflammation. So with these biologics, this was the first time that we had a disease-modifying therapy for asthma. Before that, we did not have any disease-modifying therapy. And because of these biologics, we have started talking about asthma remission, which is a whole different topic. So that was one way to phenotype asthma. There are multiple other ways to phenotype asthma. On the right side, as you can see, asthma can be early onset or late onset. Late onset is usually defined after age 20. It can be impaired or normal lung function. It can be evidence of bronchodilator response or no, or it can be controlled symptoms, uncontrolled symptoms, high exacerbation, low exacerbation, Th2 high, Th2 low. And we discussed Th2 high, if that will be one eosinophilic phenotype, its endotype can be IL-5, IL-4, IL-13 driven, or TSLP driven. So one phenotype can have multiple endotype mechanisms. And on this left side, you can see the other way to define asthma phenotype. On the x-axis is the age, childhood to adult. The y-axis is severity, and you can see Th2 high and non-Th2 or Th2 low, and there's some overlapping pattern. Within Th2 high can be allergic, it can be exercise-induced, aspirin-exacerbated respiratory disease, late onset eosinophilic asthma, sometimes very late onset, which is common in women and usually after age 40 diagnosed. And non-type 2 can be obesity-mediated, smoking-related, which is mostly neutrophilic, or can be pasigranulocytic. We'll talk more about it. So in our patient, we talk about asthma phenotypes here. Patient has late onset asthma, impaired lung function, uncontrolled symptom, high exacerbation, eosinophilic, and there's also some component of probably allergic with a little bit high IgE. And late onset eosinophilic asthma. Other ways to define phenotypes can be based on sputum cell count, which is not available here, but this can be done sometime through bronchoscopy. And so there are 4 different distinct phenotypes based on sputum eosinophils. Most commonly eosinophilic, which is defined as sputum eosinophil count above 2 to 3%, and neutrophil count less than about 60%. You can see here with the red arrow, eosinophils, and eosinophilic asthma is an asthma which is associated with high risk of exacerbation, but this asthma is responsive to inhaled corticosteroid. It can be mixed granulocytic, which will be defined as eosinophil count above 3% and neutrophil count above 60 to 61%. And you can see here, red arrow eosinophils and blue arrow neutrophil. It can be predominantly neutrophilic asthma, where eosinophil count will be suppressed, but neutrophil count will be higher than 60-61%. This is blue arrow showing neutrophil, and this white arrow showing a macrophage. Neutrophilic asthma, usually severe asthma associated with high risk of exacerbation, impaired lung function, low FEV1, and fixed obstruction, and tends to be less responsive to ICS compared to eosinophilic asthma. And the 4th phenotype can be pasigranulocytic, which is basically characterized by low eos and low neutrophils. And here you're seeing an epithelial cell with this black arrow and a neutrophil which has phagocytosed bacteria. Pasigranulocytic asthma is usually a refractory asthma, refractory to treatment, but it is less severe asthma and stable asthma compared to neutrophilic and eosinophilic asthma. We did not have a sputum count on this patient, but peripheral eosinophils have been shown to correlate with sputum eosinophil. This patient probably has eosinophilic asthma. I cannot completely exclude mixed granulocytic asthma in this patient because initially there were no eosinophils for many months on checking CBC. There's a recent study from CHEST discussing role of bronchoscopy in asthma. There are some potential role of bronchoscopy in managing severe asthmatics. This is primarily to rule out asthma mimickers and asthma comorbidities or alternate explanations like upper airway vocal cord dysfunction, tracheal stenosis, and to diagnose infections. So this study, they did bronchoscopy on all patients who had severe asthma before starting them on biologics. And they did BAL and they did biopsies on patients who had abnormal airways. And so they identified these 3 different phenotypes: non-type 2, type 2 allergic, and type 2 non-allergic eosinophilic. And they identified in each phenotype 3 clusters of diseases. One pattern was non-specific. The other one was patient had upper airway disease, most commonly vocal cord dysfunction, signs of gastroesophageal reflux, and tracheal stenosis. And the third cluster was infection, which was most commonly Pseudomonas infection. So there's some role of bronchoscopy in asthma, which is not clearly defined yet. I'll talk a little bit about role of pheno, which we check in our clinic pretty much on most of our asthmatic patients. So this exhaled nitric oxide is produced from epithelial cells and is a surrogate marker for eosinophilic inflammation. And interleukins which are involved are interleukin 4 and 13, primarily 13. And high FeNO is a predictor of response to inhaled corticosteroid, anti-TSLP, anti-4 or alpha and anti-IgE therapy. The cutoff that we use in adults, if it is less than 25, it's normal, and this is less likely to be eosinophilic inflammation. Between 25 and 50, we don't know a whole lot when it is in this range, whether this represents true eosinophilic inflammation or not. But if it is above 50 in adults, that correlates with eosinophilic inflammation and corticosteroid responsiveness. FeNO predicts exacerbation and airway hyperresponsiveness. It is important to know that if someone has high FeNO or low FeNO, it does not rule in or rule out asthma. It is not used to diagnose asthma. NAEPP 2020 expert panel recommend against the use of isolated FeNO measurement for asthma management and monitoring. We always use it in conjunction with everything else that we're doing to predict future exacerbation and response to treatment. So back to our patient after discussing different asthma phenotypes. So this patient has eosinophilic, a type 2 high, a type 2 immune asthma. I cannot completely exclude allergic asthma. This patient's serum allergy profile was negative. The patient did not have a skin test. And as I said, cannot completely exclude mixed eosinophilic and neutrophilic phenotype in this patient. That's because we did not have sputum eosinophil. Based on the symptom, patient had uncontrolled asthma with high risk of exacerbation, partially reversible obstruction, and we defined the adult onset asthma. So, when I saw this patient, so we assessed asthma control. We addressed on every visit inhaler technique and adherence, and we worked on the asthma action plan. And we discussed, Gina recommends discussing patient values and goals for their asthma medication, which is important. We'll talk a little bit more about it when discussing biologics. But the next component is assessing and addressing comorbidities. So I'll have Stephanie come and talk about asthma comorbidities.
All right, thank you. So we're going to dive in a little deeper to asthma comorbidities, which plays a really important role when we think about risk for exacerbation. It's really important that we're continually assessing and reassessing these both on new diagnosis of asthma or worsening control. So first up, just looking at some of the impacts of global comorbidities on exacerbation and uncontrolled asthma. This data was taken from, this is a 2023 article, but data was taken from the International Asthma Registry and correlated these comorbidities with a couple of different factors, but I'm going to focus on the ones, some of the highest correlations for asthma exacerbation and uncontrolled asthma. So when we think about exacerbation, found allergic rhinitis, nasal polyps, chronic sinusitis, anxiety, depression, osteoporosis, bronchiectasis, COPD, and GERD. So some of these probably aren't a big surprise to many of us, but just kind of reiterating that, there is this association. And then with uncontrolled asthma, the only really different ones here, we did see atopic dermatitis, hypertension, obesity, OSA, and vocal cord dysfunction, and COPD in that group. So we're going to dive in, not to every single comorbidity, but some of the more common comorbidities that we see. So first up, OSA or obstructive sleep apnea. And so sometimes I think we forget about really looking at this in our asthma patients. And we know that undiagnosed OSA or untreated or uncontrolled. So we see a lot of patients, right, who are diagnosed with OSA, but maybe not adequately using their devices. And we know that this really contributes to worse asthma control and exacerbation risk. And so the data here on this screen is from the OLD-OSA cohort, which was about 5,000 patients, where they looked at patients with obstructive lung disease. So they looked at asthma and COPD and this overlap of OSA. And so we know there's a lot of overlap. Specifically, when we look at the asthma patients, there was about 52 out of the 72 asthma patients that had overlap of OSA. And then you have the ACOS patients, so asthma COPD overlap syndrome patients, about 150 of those, 87 of them had OSA. So certainly there's a significant overlap. So in our clinic, we talk to a lot of our patients about risk factors for OSA, and it's important that we, test and screen them as needed for this overlap. We also know obesity plays a role. I'm going to talk a little bit more about that in the next slide. So obesity is, tends to be a big problem for us in asthma control for a lot of different reasons. We know it's risk for both the development of asthma and worsening asthma control. We know this is related to a lot of factors related to inflammatory factors being released from adipose tissue in patients with obesity. The other tricky thing is there's a lot of disparity in that, we don't study a lot of these obese patients in many of our clinical trials for asthma. So there's a large disparity in understanding asthma and obesity. But this was an interesting study looking at, it was a mouse model, but what they did was essentially looking at when we had systemic inflammation from the adipose tissue, what type of phenotype did we see in these patients? And really it was predominantly mixed granulocytic or polygranulocytic asthma in these obese patients or obese mice. And this really correlates, I think, a lot to what we understand is in obese asthmatics, we see, they tend to be more treatment and corticosteroid resistant. They tend to be much harder to treat. And oftentimes we need to be creative with some of our current treatment methods to really get them better controlled. So gastric esophageal reflux disease, the story on this has changed quite a bit in asthma over the years. And I think there's still a lot of this relationship that we don't fully understand. So the current recommendations are that there is no value in treating asymptomatic GERD in asthma patients. So many of you may have been around in a time when we empirically treated many times for GERD in patients with uncontrolled asthma symptoms without the presence of gastroesophageal reflux symptoms. So, heartburn or, other types of symptoms when they presented. But we do know that there is an association between true GERD and asthma patients that's uncontrolled, that there are higher rates of exacerbation. So you can see here, the number of exacerbations in adults increases with the percent of patients with GERD. So they do definitely can benefit from treatment if they have gastroesophageal reflux disease, and also really might need to do further diagnostics. And because there is a lot of overlap in some of the symptoms, we might need to be more aggressive on diagnosing this appropriately. And then this, I'm not going to go through this whole slide, but this was an interesting paper that looked at really this overlap of all of these coexisting disorders. So asthma kind of at the center, but we have obesity, OSA, and GERD, and really how they interplay with each other. And it really gives you this complex picture of how we need to better understand probably what's going on with these patients who have these overlapping conditions and how we can best treat them. But know that they many times come together. And so really getting a thorough understanding and workup for these patients is important. All right, moving in, shifting a little bit more to some type 2 inflammatory disorders that often coexist together. So chronic rhinosinusitis and nasal polyposis. So certainly chronic rhinosinusitis, allergies, this is kind of the traditional classic asthma patient we think of oftentimes. But we know that this, phenotype is typically noted by, as we talked about previously, elevated IgE and or eosinophils. Sometimes allergy testing is helpful, but we do know that many of these conditions coexist, right? And so this is shown here in this picture where we look at a primary diagnosis of moderate to severe asthma. You have about 60% of these patients also have comorbid allergic rhinitis, and 16% with comorbid atopic dermatitis, and about 20% with comorbid chronic rhinosinusitis and nasal polyps. And likewise, if you look at when they present with chronic rhinosinusitis with nasal polyps, they also have this overlap about 44% with asthma. So for example, a lot of times these patients, I've had patients who, have had chronic sinusitis for many times and probably have untreated or undiagnosed asthma. And the problem is that this correlates to their exacerbation risk and poor asthma control when they have these coexisting conditions. Anxiety and depression. So this is one I think many of us sometimes forget about. And I think even in asthma specialists, we don't do probably a good enough job of screening for anxiety and depression in our patients. But, you know, by kind of showing you some of this data out of the global asthma registry, is that, you know, anxiety, depression really was highly correlated with long-term oral corticosteroid use, exacerbation risk, and worsening asthma control. And so we know that these, they occur at higher rates, their risk for exacerbation. What we don't know is there's not clear data on should we be treating these patients any differently. And we probably need to understand this population and this comorbidity a bit more. But we should at least be probably screening these patients a little bit better and more aggressively, as we know that this can contribute. All right, so this is thinking about the upper airway. So most asthma specialists, we often are really curious and interested to know if the upper airway is playing a role for two reasons. About 25% of asthma patients are going to have overlapping upper airway issues. And so when I talk about upper airway, I'm considering both laryngeal, pharyngeal reflux, right? So separate from GERD, and then vocal cord dysfunction. And so when we think about the upper airway, it may coexist and be a comorbidity, but it can also be mimicking. And so it might be especially vocal cord dysfunction, we know can coexist can exist by itself and mimic asthma symptoms. So we really need to be able to differentiate this in our patients. So a couple of ways that we can do this. One is sometimes we can pick this up on flow volume loops when we look at spirometry flow volume. On the left-hand side, so these are flow volume loops down here. And on the left-hand side, we see a normal flow volume loop. It's pretty good. And then on the right-hand side, in this picture, we see some flattening of the inspiratory loop at the bottom, okay? And sometimes that will indicate that there is, you know, some type of upper airway obstruction or issue. And so these patients, when we see this, you know, clues us in a little bit more as well, and usually will require an upper airway evaluation. And then over here, we have some pictures just highlighting some of the characteristics we might see with LPR. So here we see a lot of swelling of the aeroglottic fold here and along here, along the vocal cords. We have some posterior pharyngeal cobblestoning here, and really a lot of erythema as well. And on this third picture down here, you can see there's some vocal cord nodules sitting here. And then at the bottom, this is difficult if you're not familiar with looking at upper airway, but obviously vocal cord dysfunction is hard in a static picture to really appreciate. Usually need dynamic imaging. But this is showing an early paradoxical adduction of the vocal cords. And then this is complete closure of the vocal cords as well. So really, a lot of these patients, certainly in uncontrolled patients, it's important for us to think about the upper airway and consider whether these patients, and so we share a lot of our patients with our ENT colleagues who do most of our upper airway evaluation on laryngoscopy. And usually we'll, whether it's chronic sinus disease or upper airway issues, we're oftentimes needing their input for evaluation. And then lastly, I'm going to just finish up with pregnancy. So this is, you know, for women can be a risk factor. It's interesting, the data on pregnancy, we only see about 33% of pregnant asthmatics will experience worsening symptoms, where a third actually get better and about a third stay the same. But this is not dependent on previous, so it's kind of independent in each pregnancy. So this happens a lot where I've seen, you know, pregnant asthmatics who are like, oh, I've had, you know, several previous pregnancies and I never had a problem until all of a sudden this one. So just because they did well in a previous pregnancy, you know, we kind of have to look at each pregnancy on its own as a specific risk factor for worsening asthma control. And so when we looked at this, this was a 2022 systematic review and meta-analysis that looked at some of the other risk factors in pregnancy that really correlated to asthma exacerbations. And so moderate to severe asthma classification prior to pregnancy, you had a multiples pregnancy, so twin or triplet pregnancy, Black ethnicity, depression, anxiety is showing up again here, smokers, and then obesity again here. So these are all, you know, put pregnant patients who have asthma at a higher risk. And the other really important piece on this, and if anyone has questions about this, I know we're always happy to help consult for any pregnant asthma patients, but treatment generally in pregnant patients is going to be way less risky than uncontrolled asthma in pregnancy. What I tell my patients all the time is if you're not breathing, baby's not breathing. And so it's really important that we are adequately treating these patients, especially when they're having frequent exacerbations, appropriately with appropriate guideline-driven care, and not just giving them albuterol as needed. Because we know that uncontrolled asthma is associated with increased preterm delivery, DVTs, gestational diabetes, preeclampsia, low birth weight, and maternal mortality. And even recent data has suggested that even short bursts of prednisone is safe in pregnancy. I think there's still a lot of people practicing with the idea that there are risks with prednisone in pregnancy, but that's really old data. So that's I think everything we have on comorbidities. So we're going to finish up talking about our patient, and then we'll be wrapping up. Thank you.
So we obviously assess this patient for comorbidities, and as patient did have nasal polyposis, gastroesophageal reflux, suspected vocal cord dysfunction, and uncontrolled anxiety. So we refer this patient to ENT, speech therapy, and controlled and treated GERD, and try to manage anxiety, although access issue for getting on a patient to psychiatry is one of the big barrier that still leads to uncontrolled anxiety and asthma. And this patient, what I've seen in my practice, who have uncontrolled anxiety, this patient tend to have panic attacks and tend to get VCD during those episodes. It just becomes a bad cycle. So this patient, we addressed comorbidities, we addressed inhaler technique, adherence, and exacerbation. Patient ACT score improved from 12 to 16. Still have 2 exacerbation despite being on ICS LAMA therapy. So I started this patient on mepolizumab. We'll talk a little bit more about that. And 3 months after starting mepolizumab, ACT score improved to 25. No longer had exacerbation. And impressively, this patient who seemed to have fixed obstruction to some extent, her lung function completely normalized after being started on mepolizumab. So a little bit about how we choose. This is a completely separate talk in itself. So I'll talk a little bit about how what goes into choosing a biologic. One is biomarkers. As I discussed earlier, for omalizumab, the cutoff is IgE 30 to 700. If someone has totally non-eosinophilic asthma, we can consider tezepelumab, especially if their IgE is not high. For non-eosinophilic asthma, which is oral corticosteroid dependent, we usually consider dupilumab because tezepelumab has not shown to be efficacious for oral corticosteroid dependent asthma. We always involve comorbidities in choosing biologic. For example, if patient has EGPA, mepolizumab is approved for EGPA, hypereosinophilic syndrome, as well as nasal polyposis. Dupilumab is approved for atopic dermatitis, chronic rhinosinusitis with nasal polyposis. And urticaria is one of the indications for omalizumab. Patient is oral corticosteroid dependent. As I mentioned earlier, tezepelumab is not approved, and it is not shown to reduce oral corticosteroid dose in patients who are dependent on OCS. But anti-IL-5 like mepolizumab, restylizumab, and benralizumab, as well as even omalizumab has shown to, including dupilumab, reduce OCS dose. Asthma exacerbation and trigger, if someone has predominantly allergic trigger, then I consider either dupilumab or omalizumab. We know that omalizumab is 50% effective when it comes to reducing asthma exacerbation. History of anaphylaxis, out of all the biologics, omalizumab and restylizumab are 2 biologics which have black box warning for anaphylaxis. So that goes into play. Patient values and preferences. Patient wants twice weekly injection, at-home injection, in-office injection. So that also plays into role. For example, dupilumab is available only for at-home injection. Tezepelumab and omalizumab is available both for home injection and in-office injection. Patient has plans for pregnancy. What we know so far, there's no data about any biologic other than omalizumab in terms of pregnancy safety data. What we know is probably safer. Biologics are safer in pregnancy. We just don't have the data. There are registries for each biologic, but there's decent data only for omalizumab that it is safer in pregnancy. So if someone has allergic phenotype, I always talk about risks and benefit. In this patient, actually, after she was controlled on mepolizumab, she's thinking to get pregnant, and then we're just talking about, if she would benefit just from being on mepolizumab, again, after risk and benefit ratio versus transitioning to Xolair. So that also plays into role. In this patient, probably any option between omalizumab, benralizumab, and dupilumab would have been fine. But the insurance preferred mepolizumab in this patient. That was also one of the reasons we chose mepolizumab. Otherwise, I probably would have chosen benralizumab in this patient just because we know that benralizumab has a local apoptosis effect. So a patient with very high eosinophilia, especially the high tissue eosinophilia, beside binding to anti-IL-5 receptor and reducing eosinophil production and migration, benralizumab can cause local apoptosis of eosinophil, so it's pretty helpful. And we know that benralizumab after first 3 injections, which are every 4 weeks, it is every 8 weeks after that. So it works out pretty well for some patient who like every other month injection instead of monthly injection. So that was all about our case. Stephanie will talk about what we're doing at our severe asthma clinic.
All right, thank you. So the asthma clinic, who are we? Pretty much the two of us that you've seen today. And we, a couple things, we have clinic availability in both AOP here downtown and Stony Point on Mondays and Wednesdays. We do have some reserved ER hospital discharge spots to try to help expedite getting patients who are, from the emergency room or hospital discharge in quickly to our clinics. And so happy to see any of patients for asthma, especially biologic workups. We have coordinated with our ENT, allergy, and obesity medicine colleagues to help hopefully get some quicker referrals for some of those comorbidities that we talked about. And some of the projects we've been working on, we have a growing biologic database that will hopefully be tracking our patients on biologics. We're working on developing a severe asthma treatment pathway, which will hopefully be inclusive of our bronchoscopy protocol for asthma here. We are working on a patient education pilot using a unique way to use pre-recorded videos and tablets for patients for patient education in the office and the clinic. As well as we just had our first patient education webinar, which we'll hopefully be hosting quarterly. So that was, I think, pretty successful. And then again, just improving, some initiatives to improve our ER and hospital discharge to clinic to kind of really try to capture some of that disparity of the asthma hospitalizations in Richmond. And then hopefully we'll be growing our clinical trial availability and program in the future as well. We do have a website. Unfortunately, it's fairly long, but hopefully if you really want to check us out, you probably just Google the Severe Asthma Clinic at VCU, or you can write down that link. So that's pretty much it. I think we went a little over our at 10:50, but if anybody has questions, we have a couple of minutes, so happy to entertain any questions. Thank you.
Any questions, Dog?
Yeah.
I have one question. Thank you for your talk. It's very nice. What level of eosinophilia do you start to wonder this is out of the mouth or out?
So the question was just for our Zoomers was at what level of eosinophilia are you concerned that it's something other than asthma?
It's a great question. So what guidelines recommend is if someone has eosinophils above 500, to make sure you check strongylides in United States. That's one of the common parasitic infection. But mostly, if someone has eosinophils above 1,500, then I look pretty, I try to be very thorough to rule out other etiologies like hypereosinophilic syndrome, drug-induced reaction, other reasons for high eosinophils. And sometimes patient has EGPA, sometimes patient has both, some other comorbidities causing eosinophil to be high, as well as asthma too. So, yeah, great question. Thank you.
Great talk. Yeah, how do you guys, is there any time where you start stepping down violent therapy or
Yeah, again, yeah,
So the question was about stepping down biologic therapy.
yeah. When do you step down biologic therapy? If we look at the GINA guidelines, there are guidelines for stepping up and stepping down ICS-based therapy, but there are no guidelines for stepping down biologic therapy in these patients. And there are no as such guidelines because these biologics have been around 5-6 years, most of these biologics. And so I usually look at it's again an individual personalized decision for each patient. If patient did have, like this patient who was not maintained on any therapy and had like severe exacerbation and just did not get a break for asthma to get control, this is the type of patient I usually reassess after 1 year, 2 years on biologics to see how they're doing. First, if they're doing fine, I step down, I stop their LAMA, but I keep them on ICS LABA. But if they have been exacerbation free, pretty well controlled in a year, then I try to stop biologic. In some patient, I try to increase the duration to see if they rebound. There is small data that most of these patients, when we stop biologic or wean biologic, their symptoms do tend to recur. So most of these patients end up needing biologic back again. In terms of the safety data, the longest data for most of these biologics that we have is 4 to 5 years. Longer data for omalizumab, but for mepolizumab, 4 to 5 year data, but tezepelumab, dupilumab are pretty newer, so we don't have a long-term safety data on these patients for those biologics.
Just 2 other comments on that. So I usually tell patients, this is disease modifying. So usually this is consider at least for a few years, and then we can kind of reassess. But the other thing is sometimes we utilize these too as kind of a bridge to control other comorbidities. So for example, I've had a lot of obese patients that will put on biologics, but maybe once they have bariatric surgery, they're able to get their weight down. We can then reassess. Sometimes we bridge them to get on allergy shots because their asthma is too uncontrolled. They can't get on allergy shots if that's a big trigger. So there's different ways too to kind of uniquely utilize biologics as well. So that's something to think about. But I think a lot of it's patient preference. I'd say a lot of patients feel so much better that oftentimes the more common stories, they don't want to come off the biologics because they feel so much better once they go on it. But if we find the right combination.
Exactly. Yeah, and most of these patients tolerate pretty well with minimum side effects. There's a question, what's the role of treatment of these biological agents in hypersensitivity pneumonitis? So there is no role for these biologics in pretty much hypersensitivity pneumonitis unless they have coexisting asthma, which some of these patients have. So hypersensitivity pneumonitis goes in the realm of ILD. And what we try to do in these patients, try to identify what's causing hypersensitivity pneumonitis. Some of these patients were not able to identify. Some of those patients end up needing immunosuppressive therapies. But no role of biologics in hypersensitivity pneumonitis. Other question is, how do you calculate percentage eosinophils from CBC, like 1,000? So if you look at the absolute eosinophil, it's usually recorded as 0.1 or 0.2. So 0.1 is 100 cells per microliter. So if it is 1.0, that is 1,000 cells. If it is 0.5, that is 500 cells. So that's what we use.
Yeah, so it's the absolute eosinophil count that we use, not the percentage. So that's a really good question to clarify.
Okay, last question maybe.
One more question. Yeah. If I'm not mistaken, Monty Lucas has a black box warning for anxiety. What is the data in the asthma literature between the anxiety and patients who use narcotics?
So the question was related to montelukast and the warning against anxiety and depression. I'm happy to answer, but so there is data. So I usually just talk to patients. The percentage is pretty low. I've actually seen it a lot more in pediatric patients than adult patients, anecdotally at least. I don't know, the data really supports that, but I actually just warn my patients most of the time. I think, to be honest, unless in real allergic asthma, I don't know that, I think montelukast has not, is not at the forefront. Even if you look at the guidelines, it's not really as, it's really an add-on and probably a third or fourth step. When we look even comparatively to probably a decade ago, we're just probably not using it as commonly as we used to, unless really we have allergic patients. But I don't know if you have anything to add on that.
Yeah, same. Most, like, if we look at the GINA guidelines, leukotriene receptor modifying therapies are used as more of rhinitis and allergies control than real of asthma control. They mentioned consider step 4, step 5. So I usually use it for my patients who can tolerate and don't have side effects if they have more of an allergic and rhinitis phenotype. If they can tolerate, and most of these patients, if they cannot tolerate it, if they come off, usually I've seen that the asthma does not get worse, but the allergies do get worse, and they're predominantly allergic asthma. The other question, you mentioned that SABA-only therapy would not be appropriate for asthmatics. However, there are many patients in the clinic who have very mild asthma and use their inhalers in the single digits a year. What should we increase? When should we increase to ICS for these? So if we look at GINA guidelines for these patients, they recommend ICS formoterol as needed therapy. So these patients will actually be an ideal patient to be started on low dose ICS formoterol as a single inhaler. They'll be used as needed, because when they'll get additional, when they get a symptom wheezing and they use ICS with formoterol, that would reduce the risk of future flare up. That will also decrease the overall use of their inhalers in a year.
Yeah, and the key with that is that it's formoterol and not salmeterol. So it has to be an ICS formoterol, because formoterol has a quick onset. So it's not safe to be using salmeterol. So you just have to really be careful about that and what you can get available.
Yep.
In the United States. Yeah.
Yeah, ICS formoterol comes either with Symbicort or Dulera. If someone is using Symbicort, the maximum daily dose is 12 puffs a day, which is about 50 microgram of formoterol. And if they're using Dulera, then the maximum daily dose is 10 puffs a day, because Dulera has a little bit higher dose of formoterol compared to Symbicort. But if some patient cannot afford either Symbicort and Dulera, those are the patients who have, based on guidelines, 2 different inhalers, like a fluticasone inhaler and an albuterol inhaler. So whenever they use albuterol, they'll use fluticasone or any ICS like budesonide.
So there is data, antihistamine therapy can cause weight gain over time. Are you able to limit antihistamine use? Yeah, I think that, it depends. Again, I think it depends on their comorbidities. So, and looking at the antihistamines, and then thinking about, could you use potentially montelukast or some other agents if you're concerned about weight gain. I personally haven't seen a lot of that in my clinic, that antihistamines, have been associated with significant weight gain. I don't know about you, but
yeah, usually I recommend the patients use antihistamine during seasonal change. Or they usually patient know their allergies, so I recommend them to use it during the time when they, just a week or 2 before allergies hit in, and then they get a break for a couple of months from their allergies. That will be the time they can stop antihistamine and just keep using. We're talking about probably allergic rhinitis, and they can keep using like nasal steroid. The other way to limit its use is sometimes nasal antihistamine, like azelastine is something else that we often prescribe and has been effective in these patients.
Thank you so much.
Yeah, and feel free, if you have any follow-up questions, you could reach
Yeah.
out to us. Obviously. Thanks.
Very great.
Thank
Thank you so much.
So much. Thank you.
Thank you.
Appreciate it.
Is that,
You all need the code for attendance.
that's also H1 antihistamine. I'm not familiar with that.